Hello and welcome to XKDR's Big Ideas. Our guest for today is Murali Neelakantan. Murali is an astute lawyer. He has practiced in top-tier law firms in both India and in London. He has held the position of Global General Legal Counsel in pharmaceutical companies such as Glenmark and Cipla. He is also an author who thinks deeply about healthcare in India and healthcare for India. Welcome, Murali. Thanks for doing this with us today.
Thank you for having me.
Right to healthcare right to health and medical care in India has been recognized as a fundamental right by the Supreme Court. However, it does not get enforced or implemented as easily or as accessibly as frequently as right to life or right to liberty. Several countries have adopted or guaranteed this right by adopting universal healthcare scheme models. You have the beverage models, you have the Bismarck model that is followed across different countries, and it has seen varying levels of success across countries. So today we are here to discuss how does this universal healthcare look for India, and Murali will share his thoughts on what would having this right mean for Indians, and what is the role of state in providing with this right, and how does this change the incentives of all the stakeholders who are involved. To just begin and set a bit of context, what do we mean by universal healthcare for India, and why do you think that is important?
I think we'll have to understand the term universal free healthcare. The Sustainable Development Goals say it's universal health coverage.
Right.
I prefer to use a simple, straightforward term, universal free healthcare. And what is meant by that is every Indian has free access to every healthcare need that person has. So every Indian should be able to walk into a healthcare facility and get free healthcare. It's as simple as that. The problem with using the word health coverage is the term coverage is used in insurance. So suddenly it becomes everybody should get health insurance. Why are they different? Insurance is only a way of paying money. It is not a way of delivering healthcare. And in India, unfortunately, health insurance is really, really bad. I often say that you can get comprehensive insurance for your car to cover everything, dents to replacing the whole car. But you can't get comprehensive health insurance in India. So I prefer to have universal free healthcare rather than universal health coverage.
Right. And if the component is not cost, then what else are we looking at in terms of what does this access to universal healthcare mean?
What it means really is that every time a person needs any sort of healthcare, he should be able to access it for free at the nearest or the most appropriate healthcare center. What do we need to do to achieve that? It's not really a great new idea. The CGHS, the Central Government Health Scheme, already does this, but only for the elite few. If you are in the services, you have a similar facility where in addition to the military hospitals, you also have access to healthcare in private hospitals. The Employee State Insurance Corporation provides access to healthcare in the ESI hospitals and also some private hospitals now. PMJ provides access to some hospitals, both private and public, but only for certain things. So in some form, we're trying to get healthcare for all. The most comprehensive, of course, is the CGHS. So when Ashish and I wrote our paper, we proposed that all the schemes be merged into the CGHS. And once that happens, which we think the government is likely to do very soon, it should be thrown open to everybody who's not covered by any of these schemes. So everybody should be able to opt into these schemes. Those who can pay will pay a small amount of money to participate, but a large population in India can't pay.
Yeah.
So we think almost 80% of the population, which is entitled to the free rations, for example, will not be able to pay for healthcare. I mean, they can't afford food. How do you think they can afford healthcare? So for them, it should be absolutely free to go in and get free healthcare. If now you're covering such a large population, it's virtually the whole of healthcare in India. What is left over is very little. If you exclude the railway services, ESI, CGHS, what remains is individual health insurance, those who don't have health insurance but can afford healthcare, those who have health insurance from corporates, from your employer. Those are the only three we're leaving out. And that's perhaps only a very small percentage of the population. So if we are able to get CGHS for everyone, we'll effectively get universal free healthcare. It's free at the point of use. It's not that nobody's paying for it. Those who can pay will pay for it. We have that model in India. The NHS works very well in the UK so long as it's properly funded. The people who complain about the NHS just don't understand the NHS. The problem is not that it doesn't provide a good service. The problem is that often it's not adequately funded. We think that should not be an issue in India. There is a large amount of money to fund healthcare in India. For example, the ESI has a corpus of over 13,000 crores. How many hospitals do you think that can build? Similarly, the cost of insurance, PMJ for example, is only 1,000 rupees to get 5 lakhs of cover. If we made it comprehensive, what will it be at most? 5 times that? It's like 400 rupees a month. For the population that can afford 400 rupees a month, it's nothing to get complete coverage for everybody for life. That's great value. And that's all it's going to cost. So we did some numbers and we think about 5,000 is what it costs to get coverage. We think that actual healthcare, we looked at numbers from the economic survey, and we think from the economic survey numbers that the average out-of-pocket expense is about 5,000 rupees per head, which again comes to about 400 rupees a month. So I think that's how we'll be able to get it fully funded. And therefore, I don't think it's unaffordable. I think people worry too much about it being unaffordable. India is a large country. India is a poor country. We don't have the budget. But the numbers don't show that we can't afford it.
So the natural question that would arise is, how does this justify the role of government in providing healthcare? And what is the extent to which government should be playing a role and private people's out-of-pocket spending should be given as the base 5,000 rupees per month that you're mentioning?
So the 5,000 is an average.
Right.
And as we well know, averages can be misleading. So those who can pay, those who can afford it, will perhaps pay a little more than 5,000 rupees to get comprehensive healthcare. Those who can't pay obviously will pay nothing. And there will be gradation. And that's how the CGHS works as well. Employees make a small contribution throughout their life, working life, and then they get coverage for themselves and family throughout their lifetimes.
Right.
So those who can pay will pay. What is the role of government? We think government will be like a clearing agency. So we don't think government will provide all of the healthcare. We're not nationalizing healthcare in this country. That's not the purpose of it. What we think is government will be like a clearinghouse. It will help find demand, which is the people. It will find service providers. It will agree rates with them. And all these people will get healthcare services. The government will pay for some part of it. Insurance will pay for some other part of it. So even under PMJ, we have two models where state governments can get insurance to pay for it, or they can fund it themselves. We have both models, and we're agnostic to that model. So in certain states, it may be very difficult to get insurance at a reasonable price. Secondly, in some states, infrastructure will have to be built. So we know for a fact that certain states have better healthcare infrastructure than others. In those, it may be necessary for government to actually spend the money and build some infrastructure, especially in places where private healthcare providers will not be willing to invest, at least at the beginning. Or they'll have to provide incentives for private healthcare providers to build infrastructure in some of these areas. So we think the government has many different roles. In one case, it will be procuring services ensuring there's a clearinghouse. So we'll check who's getting these services. We'll ensure that the services are provided to a good quality. At the same time, we'll ensure prices are reasonable. They can't be very low because otherwise private players won't participate. They can't be very high because that's a monopoly of the private healthcare providers that we want to avoid in this whole exercise. Patients can't negotiate rates. So government's in a great place to negotiate rates. The advantage of government building good hospitals, good healthcare facilities is that it provides a benchmark service. So we know what the benchmark cost is. We know what the benchmark quality is. And it shouldn't surprise anyone because we do have the best healthcare in this country in government hospitals. So if you take the top 10 hospitals in any city, government hospitals will be in them.
Yeah.
There will be private players, but the government hospitals will definitely make that top 10 list. So it is possible for government to deliver good healthcare service, but it doesn't have to deliver all of it. What it does deliver will achieve price benchmarking, quality benchmarking. And I think those will be the two roles that government can actually perform in this model. One, as a regulator and clearinghouse, and two, to create the benchmarks for price and quality.
Got it. What I'm hearing you say is that it should be considered on situation to situation basis, not exactly like what it is right now, that you have the schemes which will just build primary healthcare centers across the country. There will be schemes that procure for medicines across the country, but based on the demography, based on what is required, based on how much of private players can get into the system, the government has to make those decisions. But just contextualizing this for the capacity and resource constraints in India, how do we operationalize this? How do we get there? What are your thoughts on that?
Again, we have to think of this not as a national problem or as a national solution. So there'll be a framework which I've laid out for how we think we can run it. But each state is different.
Right.
The capacity of each state to deliver these services is different. The capacity of each state to procure these services is very different. What can be done centrally is get a price. And again, you might think a national price is a bad idea. And therefore, we'll have to think through this very carefully, that do we get different prices for different states, but it's uniform for each state, let's say, has a price for goods and services. It may be district-wise. So it's very difficult to sit here and say we'll have a national price for all goods and services. So yes, we must have pooled procurement. Yes, we must take the benefit of the scale that we can generate by pooled procurement. We can get benefits by rationalizing all of these schemes into one scheme. And therefore, we should be able to get better prices, should get better quality out of it. The supply chains can be rationalized. So again, we get price savings from that and better quality. So these are the techniques that we can use. It doesn't mean that you will get the same service at the same price in every place in the country. But that doesn't matter to the individual, because the individual will get the same quality of service closest to them. Price only matters to those who are procuring, and it will average out. In some states where there is a lot of pharmaceutical production, the cost of delivering those drugs would be cheaper. In some other states, it may be better to buy from another state. In some other states, they may have a benefit in terms of laboratories, which some other states may not have. So it's going to be a challenge to say we'll have uniformity in all services and all consumables and all goods across the country. Over time, it'll even out. And states will incentivize private players to play into this market. So there is a role for central government in saying, let's have a framework. The role for state government saying, we will participate in this framework. We will get the benefit of pooled procurement. We will get the benefit of a benchmark quality of service. So that's how between the center and the state, we'll be able to get both of them to work towards universal healthcare.
Got it. Just in the healthcare delivery problem in India, I think one major problem has been in understanding or monitoring the last mile to citizens, right? So in your idea of this universal free healthcare, how do we monitor that? What is the role of the state when they're also doing the role of a regulator? Are we thinking of creating another body which will monitor something like this healthcare free access, or would it also lie with the regulator itself?
So we already have the National Health Authority.
Right.
It's very unclear exactly what they're doing. They have given us all a card. So everyone who got vaccinated and used Aadhaar as a form of identification has, without consent, been given a national health ID. There is a move by the NHA to have a national health stack, which is electronic health records, which can be shared across different entities. Everybody hopefully will be able to access it on their phone. You'll be able to manage who gets access to your healthcare records and how much of it through a manager. All of this has already started.
Yeah.
To a large extent, the CGHS records are expected to finish with the electronic health record registration system fairly soon. It's a big move to get that done. There's a move to get hospitals to be able to use those health records seamlessly. It hasn't happened yet because every hospital has a slightly different way of dealing with these records. But over time, we should be able to get them to share records with each other. Over time, we should be able to understand and educate people as to how to access healthcare. Now, does everybody run to AIMS the first thing they think of? We have no other way. So you see the queues outside AIMS, there's people waiting there for months on end, almost living there. So we have to educate people as to how to access healthcare. Where do you go as your first point of call? What is an emergency? How do you triage when people come in? And it's a really important way of managing the workload. One of the criticisms of the NHS is that there are long waiting lists. But you have to understand what those waiting lists are for. So if you think about it, they'll say, old people waiting for hip replacement have to wait 4 months. Well, from a medical point of view, you're 80 years old, you already need a hip replacement in 4 months. It's not going to deteriorate so much. You're not in so much pain. And therefore, we'll deprioritize you. Whereas if it was let's say, a similar situation with a 14-year-old, then you might say, okay, that person gets priority over an 80-year-old. So there is a scientific medical way in which triaging is done. In India, we find that gory because we think I have money, I should jump the queue. And our model doesn't say don't jump the queue if you don't have, if you have the money. And that's the case in the UK as well, where you have both the NHS and a private healthcare system operating simultaneously. So even middle class professionals, millionaires will use the NHS, let's say, for giving birth. Because the difference in what you're going to get from the NHS and a private service where you can deliver the baby is really, really marginal. The difference is going to be, you're going to get a private room with a TV and, let's say, a menu where you can pick from Chinese or Italian, and they'll have pictures of babies and flowers in your room. That's really the only difference between going private and delivering a baby in the NHS. It's the same hospital in most circumstances. That the hospital is the same, it performs for the NHS, and it has one floor which is private. So we're not saying, again, that people will not have access if they want to jump the queue. So the rich will be able to jump the queue. Hospitals will be able to have a separate special ward, which is actually the exact opposite of what happens now. Now you have the vast majority of the beds are for the rich and very few for the poor. We're going to hope that this will be the exact opposite, where the masses will use 80% of the beds or the facilities, and the 10% will be for the rich who can afford to pay for these extra benefits. And so, yes, it will require a lot of reorganization in the way we think about healthcare. Who will provide the primary healthcare service? Who will be the general practitioner who will be able to figure out where the patient needs to go? So we'll work through all of that. It's not difficult. Every other country has managed to do this. Some have done it well, some better than others. A lot of Western Europe has done this really, really well. We have got good starting points because we've got Anganwadi, which works really well. You've got the ASHA workers that work really well. If we can make them professionals and not volunteers, then we have a chance that they'll be able to figure out where to send their patients. They know their patients well. They'll send them to the PHC if necessary, to the hospital if necessary, to the tertiary care center if necessary. So the last mile really, we have a good framework for it in this country with the ASHA workers. We train them better, make them professionals rather than volunteers. Then I think we'll be able to get past that last mile.
Right. That's a good suggestion, I think. Now, I just wanted to ask on for whom does this really change the rules of the game? And an allied question is also that when we do make this distinction of paying maybe an extra premium to get a faster access to it, how, does that also determine difference in quality? Maybe the better doctors work on the floor for the people who have paid the premium as opposed to the others. So how are we thinking about that?
We don't think that's likely to happen.
Right.
It hasn't happened in the UK. The same doctors will deliver babies in the same operation theater. And that is not different from anybody. So it's whether you come from the private ward where you're paying £10,000 or you're coming from the NHS wards where you're paying nothing. The babies are delivered at exactly the same place by the same doctors and the same staff.
Same facilities.
So it's the same medical facility. The medical service does not change. What changes are the freebies, the nice bells and whistles. Like I said, you'll get food from your favorite restaurant served to you. You will have a couch, 2 couches rather than just 1 chair next to your bed. And you will have beautiful decoration and curtains and pictures and maybe a larger TV. That's about it. But from the healthcare standpoint, the service is exactly the same. So it's unlikely that if we adopt this model that you will have the doctors saying we'll only treat the rich and some will only treat the poor. In fact, if you ask the doctors, they want to see variety in their training. They want to see more patients. They want to see more variety of patients for their own professional expertise to evolve. So it's unlikely that doctors are going to say, I'm only going to see rich patients. From professional standpoint, they want to actually see a variety of patients.
Because
so it's unlikely
I think in the current insurance scheme, because there are specific treatments that are approved under the scheme, they refuse to do those treatments because that will happen for free. So this is one way of...
Or the opposite can happen. So the incentives are, for example, in hospitals for hysterectomies. So we're seeing a big spurt in hysterectomies.
Okay.
Quite unnecessary because hospitals are incentivized to that. Similarly, we're seeing a big growth in cesarean births. I don't have a model position on it. As they say, no vagina, no opinion. I agree with that. But in this case, it's a really tough one to see the fantastic growth in cesarean births because the hospitals have an incentive. They get paid more for cesarean births. Therefore, so these are the kind of things when we write up the framework, we'll have to be careful of. What are the incentives? What is it that are likely consequences of this? What's going to be unseen in this whole process? Those are the things that we need to be concerned about.
And yeah, the final question is, for whom does this really, who are the people who would probably face challenges because of this approach? Who are the losers in the system? How do we convince them?
The private healthcare providers, private insurers are likely to be hurt the most for 2 reasons. One, at the moment, they can quote their price because the patient's unable to negotiate. They're in a crisis, they get to a hospital, they'll pay anything. There's no price discovery. It's a virtual monopoly. When a patient lands up in a hospital, he doesn't have choice. He or she cannot go somewhere else, cannot choose X hospital, Y hospital, no basis for it. You go to the nearest hospital or the biggest hospital and you pay whatever you have to pay for. So suddenly now you have the market forces of the government saying, okay, this is a reasonable price. Now they have to play to that price or justify why they should be charging more. So they're likely to push back and say, we don't want to play this game. But they can't push back for very long because the market's changing. If they're only going to want to service those who have a lot of money to spend without insurance, then great, that's a great market. But all those people who have a lot of money to pay and don't care about insurance, they'll still look at the alternative and say that's really quite good, which is what's happened in the UK. You know, you can give birth in a NHS hospital and you get fantastic service. Why should I pay £10,000 more for a beautiful room for one day? Not worth it. So even those who have the money will start thinking, is it really worth that much more money? So they're going to be affected primarily in this model. I am hoping that the number of patients they're likely to get more, because those are going to come into the hospital thanks to the scheme, will compensate for this loss of a little revenue at the top. They'll get more revenue, more patients, they'll be able to grow more. So that's going to be a change in their model for them. Beds will be 100% full. Currently, there are about 60%. So utilization will go up to 100%. But what they're going to charge per bed is likely to come down. That's the economics they'll have to work out. Likewise, health insurers will have to up their game. They'll have to provide comprehensive health insurance, because otherwise everybody is going to think, I can actually make a contribution to the national health scheme and get free healthcare. Why should I pay more for this? What am I getting for this money that I'm paying? So those are the two, I think, groups that will have to be convinced to join this process. They're necessary for this to work, because we have a rich population that we need to care about as well, who may want to jump the queue. And it's fine in a market to address that little niche as well. And they have the money to then build hospitals for everyone else. So let the market decide. But these are the two that will have to find their own niches and understand the threat that the National Health Scheme or the service is going to do to their business.
Okay. And I think, at least as far as the insurance providers are concerned, the electronification of the records or sharing of the records across hospitals, that would probably reduce their whole information asymmetry, which would in fact help them increase the coverage of their schemes.
Exactly. It should. They are at the moment trying to work out rates based on the data they have. And hospitals seem to be unhappy with that. So hospitals are finding loopholes and finding ways of actually charging patients more than what the insurance pays out. So again, information asymmetry exists between hospitals and patients, hospitals and insurance companies, insurance company and patients. So all of this should get better with large amount of data coming in through the National Health Service.
Okay. This was great. Thank you so much, Murali.
Free audio post-production by alphonic.com.